Hi, this is David. And in this installment, I just want to give you a sense of what a pathologist does when he or she receives a placenta and receives it for diagnostic evaluation, or receives a twin placenta. So let's imagine the scenario where there's a single common twin disc, and there's an umbilical cord from twin A and an umbilical cord from twin B, and a dividing membrane. So if there's no dividing membrane, then you know that it's a monoamniotic monochorionic twin placenta. But let's imagine that there's a dividing membrane present, so some kind of a dividing membrane here. So, but we don't know what the dividing membrane shows. So what the pathologist will do in this case is two separate maneuvers to try to make the determination. One of the maneuvers involves taking a section of the membrane or even making a roll of the membrane and looking at it under the microscope, so looking at the membrane. And another thing the pathologist could do is, if you imagine here the dividing membrane, the pathologist could take a section just like this. So imagine you cut into the placenta and cut into the placenta here to get what's called a T section. So you sort of get a section into the placental disc where the membrane comes off. So let's imagine the two main scenarios is diamniotic dichorionic or diamniotic monochorionic. So in the diamniotic dichorionic twin placenta, what you'll see under the microscope is the amniocyte layer from twin A, and then beyond that you'll see some subamniotic connective tissue and the chorionic layer of twin A. And then you'll see very close to it the chorionic layer of twin B, and sometimes they actually fuse, and then you'll see the amniocyte layer of twin B. So amnion, chorion, amnion. The second you have chorion, what I tell my residents is, the second you have chorion in a dividing membrane, it's going to be a di-di. Now once you've established it's a di-di, as we said previously, you still don't know the zygosity. And we've said that 75% of these are dizygous and 25% are monozygous, but you don't know the zygosity for sure. Whereas, if you take a look at the dividing membranes, and you see amnion of twin A and amnion of twin B, but no chorion in between, that means that the chorion only goes all the way around like this, and the chorion doesn't come in between, and this would be a diamniotic monochorionic, because there's only a single chorion, and this will always have to be monozygous. So that's one of the jobs that the pathologist has in evaluating a twin placenta, is establishing, so the first job that the pathologist will have is establishing amnionicity and chorionicity. Now, there are some, I forgot to mention that there are some gross features. It's not just the histology that gets you the answer. And I should also tell you what the T sections look like. So, on gross examination, if it's a diamniotic monochorionic, you don't see a fibrin ridge, and the membranes peel off very easily from the placental disc. If it's a diamniotic dichorionic, you do see a thick fibrin ridge between the two twin territories, and in addition you cannot remove the membranes entirely from the chorionic plate without disrupting the chorionic plate. You can't entirely remove the membranes. Now, the other thing that you could do if as a pathologist, when you get a twin placenta and you have to determine amnionicity and chorionicity, is to take what's called a membrane roll. And I meant to say is to take what's called a T section. And a T section, as we said, is a section where you're taking a section through the placenta just at the level of the dividing membranes. And so what you'll see is the territory of A, and then the dividing membranes come up, and then the territory of B. And then at issue is what you see in those dividing membranes. So if you see amniocytes on one side, amniocytes on the other, and a few vessels and chorion in between. So vessels plus chorion, that would be a di-di. And you even sometimes see some vessels running in, and then the membrane sort of tapers off, and there's usually a lot more chorion at the base, and then as you go higher up into the membrane, this is called a T section. As you go higher up into the membranes, sort of the chorion fuses more, and it becomes a little thinner, but down here the chorion will be more prominent. Whereas, in a diamniotic monochorionic, it's a much thinner membrane, and all you have is amnion. You don't have any chorion in your T section, so there's no chorion. So So those are the two ways. You could either do a membrane roll or a T-section in order to establish amnionicity and chorionicity. So that's the first role of the pathologist. And when I say role of the pathologist, I mean role of the pathologist beyond what you need to do anyways in a singleton placenta. The other thing is, if you have a case, so assuming that you have a case of either a MOMO, which is unusual, monoamniotic monochorionic, or a diamniotic monochorionic twin placenta, and let's say this is twin A, and they often mark it with one cord clamp, and twin B, and that's often marked with two cord clamps. So this is your dimo placenta. So in this scenario, you need to look for vascular anastomoses. And so if this is the umbilical cord, what will usually happen is that the vessels will ramify off the umbilical cord, and let's draw the vessels of the other twin like this, and there's usually an equatorial plane between the two vessels. There's usually an equatorial plane, and you need to assess the equatorial plane to see where it is. And by the way, the equatorial plane is usually not where the dividing membranes are. So the division of the vascular territories between the two fetuses are not usually the same place. This might be where the membranes come off and divide the two fetuses. And the vascular equator is here. So the placental disc is shared here, but the membrane division is here. So don't make the mistake of assuming that the point of the dividing membranes is the point of the vascular equator. So the other thing that the pathologist wants to do is look at the vascular equator and quantify how much of the disc parenchyma went to A and how much of the twin parenchyma went to B, because unequal sharing of parenchyma, unequal distribution, could lead to asymmetric growth restriction of one twin versus the other. And then the other thing that the pathologist wants to do is look for the presence or absence of vascular communication. In a di-di twin placenta, vascular communication virtually can't occur. In a di-mo situation, vascular communications are abundant, and they're so abundant that for complex reasons, twin-to-twin transfusion isn't really a problem, because there's so much sharing. But the problem really arises in a diamniotic monochorionic twin placenta. That's where the problems could arise. And you could get vascular anastomoses between twin A and twin B, and those vascular anastomoses could lead to the twin-to-twin transfusion syndrome. And that'll be the topic of the next installment.